Well, thank you for joining us for Conversations and Cases in Oncology, updates in the treatment of early non-small cell lung cancer, expert opinion. In this segment, we will be discussing therapy in special populations. I am Dr. Julie Brahmer, co-director of the Division of Upper Aerodigestive Cancers program at the Johns Hopkins Sidney Kimmel Comprehensive Cancer Center, and I'm joined by my esteemed colleagues, Dr. Stephen Liu and Dr. Jamie Chaft. Welcome. So I'm going to actually present a case that highlights some of the challenges for special populations, specifically those patients with potential driver mutations. So put on your thinking caps, both of you, and I need some suggestions. So the other day, I had a 67-year-old woman with a history of never smoking. So she was a never smoker. She presented with a cough, and a CT scan showed a 4.5 centimeter right upper lobe mass. There were some borderline enlarged lymph nodes, and then the PET scan showed the lung mass and hilar lymph nodes were avid on PET. EBS was negative. And so she underwent a right upper lobectomy, lymph node dissection, and at that point, she was found to have a 4.7 centimeter adenocarcinoma. Her actual lower 4R was positive, but the rest of her lymph nodes were negative. So in this situation, would you push for PD-L1 and NGS, or just move on to adjuvant therapy? Thoughts? Stephen?
So this is a case where I would definitely do NGS, right? Coming in as a never smoker, you have a higher pretest probability, a higher suspicion that there will be a driver at the root of this tumor. And so I think NGS is important. We favor, when possible, DNA and RNA sequencing, but I think NGS in some way is critical here. PD-L1 will kind of come along for the ride. I think it probably plays a little less of a role in this never smoker, but we would definitely do driver testing here.
I've had some folks who say that they get pushback from their pathologist about doing a whole panel NGS. Jamie, you have a special group who is great at doing all of this, but what if you get pushback? What should you say to your pathologist?
In the adjuvant setting, it's a little tricky. Disease is completely removed. So the indications for various targeted therapies are few. However, this information guides us. It really helps weigh the risks and benefits of all of our therapies. And I actually think it's essential. So we push back pretty hard, particularly in this setting, because time is available where it's often not in, for example, the neoadjuvant setting. So I think the pathologist has a large tumor and you have a bit of time to make your clinical decisions. So it's worth that extra push.
All right. Well, in this case, her tumor had an EGFR exon 19 deletion, and her PD-L1 came back 66%. So what would you recommend for adjuvant therapy in this case? Jamie, what are your thoughts?
I would recommend adjuvant chemotherapy first, followed by adjuvant osimertinib for this patient. We've seen randomized studies that compare chemotherapy to TKI, and they don't look so wonderful. So I do think that there is a role of chemotherapy. While the ADAURA data showed a comparable benefit of the osimertinib if chemo was or was not given, it didn't really ask the question, is chemo necessary? So for this patient with high risk stage 3 disease, I think it's worth offering both.
Would you do the same, or could she convince you just to give her osimertinib, Stephen?
She could try. I am going to really try to stress the importance of adjuvant chemotherapy here. Just like Jamie said, the difference here really is in a proven survival benefit, something we don't have yet for osimertinib. And if we think of the subsets where we don't see a whole lot of difference in terms of outcomes if people did or did not receive chemotherapy, I'm not sure you would expect to see that at this point. Because based on where ADAURA is, patients were receiving osimertinib for 3 years. It's kind of where we saw that snapshot in time. I think the benefit of adjuvant chemotherapy would be seen much later after we stop the osimertinib, hopefully translating to an improvement in survival later. So I still think there could be a difference in that group. I think chemotherapy is still our standard of care as long as it's safe to do so.
So what if the patient was like, but my PD-L1 is 66%. I don't care if I have an EGFR. I need to have the immunotherapy instead. Is there any situations or anything that you would say that maybe would convince you to use IO in this situation?
So not for us, and that is something actually I find patients very well informed, and immunotherapy has really seized the narrative across the lay media and the public press. But we know actually a lot from the stage 4 setting that PD-L1 expression in the context of an EGFR mutation simply means something different, and it's not the sign that this tumor is using the expression of this checkpoint to evade T cells. Really is the result of this aberrant signaling. So it has a different meaning. It doesn't mean the same thing. And we know from, for example, Dr. Eddie Guerin's single-arm phase 2 that even PD-L1 high non-small cell lung cancer generally do not respond well to immunotherapy.
What about in the Keynote 091 study that did seem to show an advantage of giving pembrolizumab for EGFR mutant disease? Does that make sense, Jamie?
It doesn't make sense to me. The data doesn't make sense to me. And these patients also weren't given the opportunity for osimertinib. So I think it's similar to the confusing settings we have in stage 4 disease where trials move so fast that your comparator arm is no longer standard. I think that's what happened in that study. I mean, we would no longer consider placebo the right treatment for that population. So the right study, if it were ever to be done, which it probably would not be, would be adjuvant osimertinib versus adjuvant checkpoint inhibitor.
Yes, I agree. For the Keynote 091, it was interesting. The hazard ratio was 0.44 for those patients. And again, I agree. It just doesn't make biologic sense in this situation. But it would be potentially a great jump off for a possible trial down the road. And then in the Empower 010 study, that study made a little bit more sense for our EGFR mutated patients where there wasn't any benefit to receive adjuvant IO in after surgery. And really the hazard ratio was right on the mark at 1. So I guess, Stephen, I wouldn't recommend giving IO in this situation either. And I think also I'd love to have more information out of these trials about the different driver mutations or fusions. Only the Empower 010 study actually showed some data for patients with ALK rearrangements. And again, in that group of patients, it was quite small. There was no advantage for these patients to receive adjuvant IO therapy after surgery. So I think even in our ALK patients, I wouldn't recommend adjuvant IO. So you agree? Are you seeing anything?
We're seeing a lot of those discussions, but I think one point that really work done by Jamie and her group is that we also know that the sequence of treatment kind of matters too, and that's sort of a unique situation in our disease where here the order of therapy seems to dictate toxicity. If someone were to receive adjuvant immunotherapy and then unfortunately did relapse, it might actually be a little more difficult to then deliver that targeted therapy.
Right, exactly. So what about in the neoadjuvant setting, for patients with driver mutations or these fusions? And none of our studies in the neoadjuvant setting include patients with obvious EGFR or ALK. Again, I'd love some data with some of these other mutations, but certainly if this patient came in and we knew before surgery that she had an EGFR TKI, would you offer neoadjuvant IO or would you offer neoadjuvant TKI if she had a single station N2 positive or hilar lymph node positive disease? Stephen?
I hope I'm not going to be embarrassed by my answer. I probably would not offer neoadjuvant immunotherapy in the context of an EGFR mutation. In this setting, I think that one could potentially move to surgery and consider adjuvant targeted therapy. You could consider neoadjuvant chemotherapy, surgery, and then adjuvant TKI. I think neoadjuvant TKI makes a lot of sense. And I think that the ongoing studies hopefully will answer that question. We'll have to see sort of what benefit comes from studies like NeoAdora, giving TKI beforehand versus chemotherapy or with chemotherapy. I'll be interested to see those results, but it stands to reason to me that those would be a benefit.
Jamie, the LCMC group has a lot of very interesting trials ready to go or ongoing. And can you tell us a little bit about these associated trials that are kind of under the LCMC umbrella?
Sure. The LCMC is the Lung Cancer Mutation Consortium. It's a group of academic institutions that has worked together to perform studies over the last decade or more. We will see some data forthcoming about neoadjuvant immunotherapy in patients with EGFR and ALK-driven tumors. They were included in the completed LCMC3 neoadjuvant atezolizumab study. And the ongoing efforts are really looking to be far more precise than that. That study was a all-comer study of neoadjuvant atezolizumab, looking to learn from predictive biomarkers. Moving forward, we're hoping to assign precision medicine matches in the neoadjuvant setting. So the LCMC effort is really a screening umbrella study that will provide genotyping, both plasma and tumor genotyping in patients with potentially resectable disease. And then there is a whole host of therapeutic studies that patients can enroll on, really targeting almost every oncogenic driver mutation that we can target to date. Some are still in development, such as one at your institution, Julie, with KRAS G12C inhibitor, as well as studies in development for EGFR exon 20 and HER2. But all of the other drivers with approved agents have neoadjuvant studies available somewhere in the U.S.
Awesome. Yes, we just talked about the NeoAdura, looking at neoadjuvant osimertinib or osimertinib plus chemotherapy compared to chemotherapy prior to surgery. And then there is also a study looking at neoadjuvant as well as adjuvant for patients with ALK fusions, ROS1 fusions, NTRK, as well as BRAF V600E with the appropriate TKI. And that is those trials are ongoing. Certainly in that we have the neoadjuvant ALK under that LCMC study, but there are plenty of adjuvant studies for ALK. Currently, the main one that's still open is using crizotinib in the Alchemist trial. And then just recently completed is the phase 3 trial looking at adjuvant alectinib versus adjuvant platinum-based chemotherapy in patients with resected ALK-positive disease. We also have the Libretto study that's part of the LCMC umbrella for RET-positive patients looking at cell percatinib, and then also a study for MET-positive, both for MET exon 14 skipping mutation or even high MET amplification in the geometry N study. And so it'll be interesting to see those results as they come. So again, stay tuned. I think for our patients with driver mutations or fusions, there'll be more studies and more data to come. So
the preliminary ALK experience will be presented soon. And the rest, well, they're wonderful opportunities, but the data are quite far off.
Wow, that's awesome to hear. I can't wait because I get that question in clinic. Doc, I know those TKIs work. Why can't I just have them after surgery? So what should we do for unresectable? So what if that patient was just straight up, she had the right upper lobe mass, mediastinal adenopathy that was enlarged, and they were very bulky, and she was deemed not to have a resectable disease, and she had EGFR exon 19 deletion positive disease and high PD-L1. So do you just treat those patients with osimertinib, or do you give them concurrent chemotherapy and radiation? Stephen?
Our standard right now is still concurrent chemoradiation, and I view that as potentially a curative modality. But I think in the presence of a sensitizing EGFR mutation, we probably would not offer durvalumab in that setting.
Jamie, what about you? What do you do in that situation?
I agree. It depends for me on the number of lymph node stations and how bulky they are. If someone has bilateral supraclavicular disease and an EGFR mutation, I would probably ensure they've had some sort of induced response to osimertinib before holding and offering chemoradiotherapy. If it's a patient, as you presented in your initial case, just not resectable, then I think upfront concurrent chemoradiotherapy is still the standard of care. However, I would be resistant to offer durvalumab based on the risk of complications if they were to relapse and thereafter need the TKI.
Yes, there's definitely several studies that have showed that for those patients who have received durvalumab and have a high rate of recurrence anyway, require osimertinib after that, there are case series that show that some of these patients will develop pneumonitis due to the osimertinib. And recently presented at ASCO by Dr. Naito showed in the Pacific subset of patients with EGFR mutations, there was no difference between durvalumab or placebo in progression-free survival or overall survival. So again, I don't recommend durvalumab in that situation in patients with EGFR mutant disease. For ALK-positive disease, I probably would not offer durvalumab either. But do you guys feel any differently?
No, I agree.
I agree.
Yeah. Well, I want to thank both of you for being here today. And so please be sure to click on this activity landing page to claim your AMA, ANCC, or ACPE credit to access other topic segments such as adjuvant and neoadjuvant therapy in early stage non-small cell lung cancer. Thank you.